Okay, thank you very much, and thanks for staying. I know it's in the afternoon, and yeah, that'd be great if we could get some good ideas and suggestions so we can plan for next year. So let's talk about NPO during labor, and are we being too restrictive? So you might know that I'm from the Western Pennsylvania area, and I might have a little bit of a dialect. And it was interesting because on the Discovery Channel, I was looking, they were talking about the different dialects that you have in the United States. And it pretty much goes by latitude. And up in Canada, you have the dialects there, you have the North Central, you have the North, the Midlands. So we're going by latitudes, the South. You have the New England up in Boston area, the New York, New Jersey, Charleston, even certain areas of the South. Looks like the West, they're just like totally, all by themselves with their one dialect. And if you look sort of right here in Pennsylvania, there's a dialect right there. So like Pittsburgh and Morgantown is just pretty much right there. So if I have a dialect, it's because of where I was, grown up and stuff. So I thought I'd just share that with you. Okay, so let's move on. The objectives, what we're going to learn today is we're going to discuss reasons why women have restrictions on oral intake during labor. We're going to discuss the advantages and disadvantages of allowing oral sustenance during labor, and we're going to discuss the characteristics of an ideal oral supplement. So what I wanted to tell you is that this happened in like 2013, where we did a little study and we looked at giving sustenance during labor, and specifically it was giving a protein drink and looking at outcomes. And we submitted it to SOAP and it got accepted. It was like a poster presentation. And then we also submitted it to the ASA. And at the ASA, every year they pick about 20 abstracts where they send out to the media, and it just like goes, and it just like a hot topic and all that. So for 1 year, it was that this abstract just like caught on fire. So what I want to say is that this oral sustenance and NPO and labor is a really hot topic. And society is looking at it one way. It's like, why are we not allowing our praetorians to eat during labor, but yet in anesthesia we're like rigid and we're really worried about aspiration. So it's almost like we're off to the left, society and the lay people are off on the right, and maybe we need to meet somewhere in the middle. So that's my objective today. So this was the abstract that appeared at ASA 2013. So in a way, it was like sort of my 15 minutes of fame. And then I was just like, you look on the internet and you see all what goes on, and I'll show you what happened. So of course, this was presented at the ASA, and women in labor can ditch ice chips and drink a protein shake instead. So this went out to the media, and then it just like blossoms. How can it went on a Medical Daily? Say goodbye to ice chips, protein shakes, ease starvation for women in labor. It also hit Medscape. Protein shakes during labor does not delay stomach emptying. So it's like every day I go on the internet, it's like, wow, this is like good stuff, you're getting all this press, and so it's good. So my head's maybe expanding just a little bit, so we'll see how it goes. But then this is Ted Yagmore, who is the SOAP ASA representative. He basically says, moving toward a low particulate matter during labor would be difficult for most anesthesiologists to accept. And I'm like, oh, we're making all this like good, we're going in the right direction. And they're like, he's doing like the official like ASA stance or something. So we really need to look at this and see what's going on. So then continuing, this is like a hot topic. A lot of groups out there are really pushing this, and they're looking at it. Pregnant women who drink protein shakes during childbirth may feel more satisfied, study says. Science Daily, women in labor can ditch ice chips, drink protein shakes instead. So you can see it's sort of a hot topic. There's even another one that's going, and in fact, it's even went into Anesthesiology News, which, I know it's like a throwaway journal, but most people, more anesthesia providers read Anesthesiology News than all the other like journals combined. So it hit there. And also ABC News, women in labor may be fine taking in nourishment. So Diane Sawyer. So I'm like, wow, this is pretty big. Fox News, same type of deal. So it's important, and every year it goes. And in fact, this past ASA, there was another abstract that said that laboring parturients should be able to eat during labor, and then I'll show this later. But basically, the ASA came back with the stance about, people should remain NPO and not take solids. So we'll go more into it as I progress. So since the 1940s, physicians have attempted to lower the risk, and you really worry about Mendelsohn Syndrome. You're worried about aspiration, and we know back then that a lot of times, even before labor epidurals, you had inhalational anesthetics, so then once you went unconscious, you increased your risk for aspiration. And because of that, and because of the worries about aspiration, that the typical diet during labor is pretty much just ice chips. So once you get that labor epidural, nothing to eat, you can see why. But the actual risk of aspiration is definitely decreased. It used to be 7 to 15 per 10,000, but since 1979 and 1990, the risk is now 7 and 10 million. So that's like a 1,000-fold difference. So the risk of aspiration is very much less. But still, I can see where we're coming from. It doesn't, if you have one patient that aspirates, that's still a problem, and you don't want it to be your patient. So it's a big deal. So why is that? Why is it increased or decreased 1,000-fold times? And it's because we have improved techniques. We pretty much just do regional anesthesia. We avoid general anesthesia. We have the difficult airway algorithms and also the new devices that are available. So being NPO, and we all know that if you have a laboring parturient, that it does increase the incidence of dehydration, hypoglycemia, dissatisfaction, and anxiety. And we also know that consumption of a light diet during labor does not influence obstetric or neonatal outcome and or emesis. And in fact, there's a difference between solids, of course you don't want to eat solids, and also liquids, and then you can also have like a light diet. And I remember when I was an intern, we used to say like after surgery, or if you're going to advance, is having a brat diet, so bread, rice, applesauce, and toast. So that's totally different than like something that's totally solid with a high fat content like meat. So the ASA task force has even stated that an oral intake of clear liquids during labor improves maternal comfort and satisfaction without increasing maternal complications. And then there's other groups like the Society of OB and Gynecologists of Canada and the WHO, World Health Organization in Europe. They recommend that all women should be offered a light or liquid diet according to their preference in labor. So, and also, even with like nitrous, like I said, in Finland and Europe, there are some areas that are more liberal. So like the Netherlands, United Kingdom, they can be more liberal, especially in like Finland and those areas, that they'll just like, give them a whole like diet. And I'm not sure we want to go that far. And they still have the same complications that we have or less compared to what we're doing here. So what about Mendelsohn Syndrome? And we talked, that was mentioned earlier this morning. So he stated that lung injury increases markedly when an aspirative pH is less than 2.5 and the volume is greater than 25 milliliters. And here's his original paper. You can see it in French. And we also know that if you have aspiration, it takes a while before it shows up on the x-ray. And it's just, at the time of aspiration, it takes a while for it to consolidate, as you can see here. So so the ASA says that a specific fasting time for solids has not been determined. And really probably is not a good idea to mess with solids when you're in labor. There is insufficient evidence to address the safety of any particular fasting period of solids in OB. The ASA consultants agree that maternal intake of solids does, during labor, increases complications, and that really you should remain NPO 6 to 8 hours for elective, like a C-section or tubal, and just like we would for regular surgery. So same standards should apply. So our institutional NPO status, what we recommend is that all women beyond the first trimester are considered full stomachs, and then they should be. And being pregnant and with the increased gravid uterus and the increased risk of reflux, then they should be considered full stomachs. We still do 6 to 8 hours before an elective procedure. No solids during labor. But clears are okay up to active pushing or 8 centimeter cervical dilatation. So that's pretty consistent with the ASA guidelines. So traditionally, and we said this before, just by being pregnant does not mean that you're delayed in your gastric emptying. Now labor can do it, it can delay gastric emptying, and it was thought that because of the increased abdominal pressure and because of progesterone, those effects slowed gastric motility, and it has subsequently been shown that it does not. So we also know that being NPO, it causes patient dissatisfaction and it can negatively impact the experience of labor. And we talked this morning earlier that, it's really not just the pain scores, but it's the overall satisfaction. It's, how satisfied were with your delivery experience. And if you were satisfied, are you more likely to come back again? So those are all important, and that should be the key indicators. So we do have improved general anesthetic techniques, and it has decreased the incidence of aspiration, and like I said, it has decreased 1,000-fold. So 1 in 10,000, as it used to be, to at least like 1 in 10 million. So that's a long time. So what are the advantages if you do an oral intake? So we know that going in active labor, that's analogous to a moderate aerobic activity. So it's a workout. So you could use some sustenance or you can use some calories. So women too who are in control of their labor, they report a more positive experience. So just by during the PCA epidurals, that's a more positive control. By getting them maybe sustenance that can be in more control of their labor and have a better patient experience. So offering an option for sustenance may improve the sense of a woman being in control and what happens in labor. So what is the ideal oral supplement? If you're going to give somebody, what would it be? Well, it would be in liquid form, it would be isotonic, it would be normothermic, and have a neutral pH with the low residue. So it sounds like water or what we're given or ice chips, but you want to have some calories. So that's would be ideal. Like I said, moderate aerobic activity, so it's important to do. So where did this protein thing come out, and why protein? So a high protein is anything that has more than 30 grams of protein in it, and it's been shown in cancer chemotherapy patients that if you give someone something high in protein, greater than 30 grams, before chemotherapy, that it does decrease the incidence of emesis and nausea in anywhere from 5 minutes or 45 minutes before treatment. So the same type of deal. So we know that there's nausea in pregnancy, there is emesis in pregnancy, so if you gave a protein drink, not only would it maybe increase satisfaction, but it would give you some sustenance and it may decrease nausea and vomiting. So that's what we looked at. So traditionally thought that gastric emptying, like I said, progesterone effect, an increase in abdominal pressure, and that all delayed gastric emptying. Labor pain in and of itself can decrease gastric emptying, and that's true, and it can provoke vomiting. And the feeling of nausea, it's almost like you have irregular movement of the stomach muscles. So it's almost like it's like AFib or something like that. They're just not moving in regularity and normality. So by protein establishes the normal steady rhythm of muscular contraction in the stomach. So that's what protein does. So that's, and that was the thought behind it. So what we did is just to show you what came out of it and the protein drink, and I was going to show you too the movement, and we also studied how protein moves through the stomach. So we wanted to look at the incidence of nausea, vomiting, emesis, and also patient satisfaction with the protein drink. And really there was no funding, and I was just looking around for something that had 30 grams of protein, and I found it at Costco, and I happened to be a Costco member, and I wasn't given any funds or anything like that. I had to pay for myself, and I know I could have got like 30 of these protein drinks for like 20 bucks. So I was like, oh, it sounds good, it's got 30 grams, so that's why I used it. So as far as the indications is the inclusion criteria, so we studied 150 patients, and we wanted them to be childbearing age, we wanted them to be prime, we wanted all groups to be equal, less than 5 centimeters cervical dilatation. You didn't want to like feed them at like 8 centimeters or 9 centimeters, and then it's a rush and then they aspirate. We wanted them at term, so greater than 36 weeks gestation, singleton pregnancy, and at least NPO more than 4 hours. So we wanted to make sure that their stomach was pretty much empty before they came. Exclusion, and it's probably the same sort of recommendations. People that are IV drug abuse, because we know narcotics slow gastric emptying. People that had gastric bypasses are probably not a good patient. people that have insulin-dependent diabetes because the gastroparesis are not good, and then also history of known obstetric or medical complications. So here's the protein shake, and that's what it looks like. And there you can get 3 kinds. There's like strawberry, chocolate, and also vanilla. And it has, and then I'll read what it says, and almost like, wow, I want one. So it contains 30 grams of protein, 1 gram of sugar, 8 essential amino acids, and 24 vitamins and minerals, and has 160 calories and 325 cc's. So that's what it looks like. And so instead of giving that, you got that. And what was funny is when we gave these protein shakes, we signed them up, and some we just gave ice chips, some we just gave the protein shakes, and I didn't even have any patients, and I'd have like labor and delivery room nurses come up to me, oh, can my patient have a drink, can I have a protein drink? And I said, well, officially they needed to be enrolled in the study, so that's how popular it was. So what we did is we looked at nausea and emesis, and then also at hourly intervals, and then we also did it 1 hour after delivery, and then we also looked at overall patient satisfaction. How satisfied were you to have the ability to have oral sustenance? And then another thing, and one of the reasons I brought this study up is that we also did ultrasound views. So, normally you want the patients to be left uterine displaced. So to look at their ultrasound, you have to be right uterine displacement. And what you do is you use ultrasound. And I wanted to see how fast, we looked at water, ice chips, how fast does water go through the stomach, and how fast does this protein go through the stomach? Because you wanted to be sure how fast it goes, and I think it's really important to come up with the results. So what we did is ultrasound view. We did it at baseline, and we did it every 10 minutes on an additional 18 patients, and we did it for 2 hours because we knew for sure that probably within 2 hours it would be gone from the stomach. So no other foods or drinks were allowed, and then this is where you look. So you look right here, and you look at the gastric antrum is right there, and it's this area right here, and it's round, and it just basically expands. So if there's a lot of fluid or a lot of content in there, it expands like this, and then it just pretty much goes down and goes down to 0. So we did it at baseline before they did it, and then we looked at it. And on this side, I'll just show you. So here's the ultrasound where you can look right here, and you can do this in patients if you want to, and it's easy to learn. And there's the gastric antrum right there. So yes. Okay, so here's what, after drinking a protein drink, it looks like this. So this starry glass, this is the protein drink, and that's what it looks, and see how expanded it is, and then it just expands real small. And then this is clear water. And the measurement is, I'll go back, here's the measurement in, go back. So the measurement is, and how you do it is the combined surface area is the AP diameter times the cranial caudal. So you do AP diameter this way, cranial caudal that way. You multiply it by pi and you divide by 4. And that'll tell you how much volume is in there. So that's what we did, and that's how it looks, and then it just expands real small. So, and what we found out is we did 150 patients and like 75 or so in each group, and that we found really no differences in the incidence of nausea, although nausea was higher in the control group. It was 33% compared to 20%. And emesis was also higher, but none was statistically significant. It was 13% in the control group, and the patients that had the protein was 4.8%. And probably maybe if we enrolled more patients, it might have become statistically significant. But we also looked at patient satisfaction scores. How satisfied were you with the ability to have something to drink, have some oral sustenance, and rated from a 0 to 100, and it was statistically significant. The p-value was 0.007. And then in the 18 patients, and that's what I wanted to really relate to you guys, is with the 18 patients, we looked at how fast did both water and the protein drink get removed from the stomach. And if you look, right, it was 25.6 minutes. That's all it took for protein to be removed from the stomach in a laboring patient with an epidural, as opposed to if you just had water, it was only 20 minutes. So there's really just like a 5-6 minute difference with the protein drink. So if you do like 2 standard deviations, so probably within 2 hours. That's why they say if you're having a liquid diet, you have 2 hours. So probably within 2 hours with the 2 standard deviations, you're well within and it's going to be removed. So with the protein drink, it's gone within 25 minutes. So even if they're like in early labor, maybe 1 or 2 centimeters dilated and they're not progressing really fast, if they have this drink or protein drink or they have a light liquid diet, it's going to be gone in an hour or 2. So you don't have to worry. So you can feel more comfortable in going ahead and allowing that to occur. So it has been shown that ultrasound gastric emptying is preserved. So it's not, if you're not in labor, there's no delay in gastric activity. And in fact, it really shouldn't be a problem. It's only when you get narcotics, and also narcotics in the labor epidural, that can also slow down gastric emptying. So I also wanted to show, this was a study that was done up in Toronto where they use a lot of ultrasound, and there was 2 ways that they measured. So this way here, they just did the same thing. They did the cranial caudal measurement and the AP diameter, or on those OB machines that you can also draw a circle. And what they did here is they drew a circle. Free tracking method is what they call it. They just drew a circle and they compared the differences, and they both were like, they had really good, like 100% concordance. So you can either measure it by doing the measurements, the AP, cranial, caudal, and then you'd have to calculate it. Or if you did the tracer method, right here, you just trace around it, and then that can give you the volume right there. So that's just as good if you were going to do it. So recently, and it was amazing because, as I'm on the board of directors and there's a lot of other members here as far as soap goes, and this thing came out with ASA. So another thing about, and they talked about most healthy women would benefit from a light meal during labor. So now it's not only a protein drink, now they're like pushing, like we're giving light meals and stuff. And if you read the abstract, and this was published by the ASA, and this was an abstract and same type of deal, it went to media and it like caught flight and took all over. And it was funny is because it wasn't even vetted by SOAP. We should have looked at it. So in the future, we're going to be able to look at it and make sure that things go. But just because it's that public that's really pushing, they're looking for catchphrases and things that are really striking a chord with the lay public, and we really need to try and adapt and move the box forward. So what ASA did is they made a statement and pretty much just said this right here, which was that at the past ASA House of Delegates meeting on October 23rd, practice guidelines for obstetric anesthesia and updated report were passed. On page 12, it says that the language that solid food should be avoided during labor. And it was funny is the authors of this abstract, they were like medical students and like saying they were do that. And they're obviously not experts, on who should be getting sustenance or not. So it is striking a chord, and it's things that we need to address. And what's funny too is that I was looking online, and there's things on the web blog that are being said that you don't even know, and it's very hard to read, and it's for me to it. But it's I could just tell you that some of it says it like about time, finally someone's doing something. This is what society is saying. Another thing is they let me have Sprite. I'm not sure I would have made it through without something other than ice chips. So this person is, oh my gosh, just to have something other than ice chips, struck a chord. I was allowed to eat anything I wanted during labor, had pasta, salad, and crisp. It's like, oh my gosh, so you don't want to go too far, okay? So it is funny. It's funny to read what people are saying. And this one, it's funny too. It says, it seems only in the US and other places, highly medicalized areas, that they restrict you, and having an option is a good thing. And then other things, and then, oh, this must have been Ted again, because he basically just said, oh, the sample size was low, and I'm not sure we should be allowing this. So that was funny. Here it says, when we talk about labor, we talk like you're going to deliver, and this just basically says you can't equate just, being in labor with like immediate delivery. There is a position in between, and the lay people, they noticed that too. And one of them said, I ate all kinds of stuff and I threw up. So it's like, oh, but it felt good to be able to eat. So that's what's out there. So we really, that's why we have to restrict. We can consult with them and tell them, what's best for them. So the key points: the volume of liquid is less important than the presence of particulate matter. Solid food should be avoided in laboring patients. I totally agree with that. And one of the reasons is that, you have like these chunks and stuff that are degrading, and this is like what can happen in your lungs. And you don't want this like chemical pneumonitis. It can cause problems. So I honestly believe that solid should be avoided. But an oral intake of maybe a protein drink, maybe a light diet, like a brat, like bread, rice, applesauce, toast, something really small that goes through, maybe early in labor would be okay. And we talked about the times how food goes through the stomach. And the complicated patients, for sure, no way. So diabetes, gastroparesis, morbidly obese, difficult airway, you want to do what's safe for both mom and baby. And patients under elective C-section, or if they're going to have elective tubal, you really should wait 6 to 8 hours, as we would for a normal patient that's undergoing regular surgery. So in conclusion, anything we can do that can increase patient satisfaction is a major positive. We really need to, like, instead of being way on the left, we need to become more center, and we need to adjust to what the society wants. Physicians and clinicians should feel comfortable replacing ice chips with water, and that maybe, more liberal guidelines we should explore. And I bet you that this topic is not going to go away. And that's it. Thank you. Appreciate it.